So my name is Dale Schaller. I'm an independent health policy consultant. I'm focused on patient experience measurement and improvement, also patient engagement. And I've been a longtime member of the CAHPS consortium. I'm pleased to be the moderator for the very first part of our research meeting that is focused on engaging patients and families in survey development and other research. Next slide, please. Our first session of two this morning in part one will begin by addressing the CAHPS survey development process and how it all does start with patients, families, and communities. And we're really fortunate to have two speakers who know a great deal about both survey development and involvement of patients and families and community stakeholders in that process. Our first speaker is Julie Brown, who is a senior study director and also the director of the RAND Survey Research Group. She will be talking about the CAHPS survey development process and how it is designed. Julie will be followed by Susan Perez, who is the professor a professor of public health at Sacramento State University, and she will be offering a patient and community engagement perspective on the process and steps that Julie describes as what we use in the CAHPS survey development process. And I just want to say that the pairing of Julie and Susan together is a very deliberate design feature of our meeting today. We're using kind of this dyad of having both a professional research perspective coupled with a patient family engagement perspective so that we actually understand how the two areas and perspectives intertwine and can be mutually supportive together. Next slide, please. So as you know, the bios for every one of our speakers today are included on the event site, but I'm just going to give you a little bit of background before we get started on both Julie and Susan. So Julie is also a longstanding member of the CAHPS consortium. She leads the survey instrument team as part of the RAND CAHPS team, and she has specialized expertise in the implementation of CAHPS surveys for the Medicare programs. Susan is a health services researcher who brings together the perspective of patients and community members and other stakeholders to inform the development of healthcare policies and information and resources to promote equity and high-value outcomes. And I will mention that she was recently part of a technical expert panel that does include a number of different perspectives, including patients, for developing a new CAHPS maternity survey. So she brings that perspective to the conversation as well. So with that, I'm very pleased to turn it over to you, Julie, to get us started.
Thanks so much, Dale. Thanks everyone for joining us today. It's great to be here and great to get to talk about or give you an overview of the CAHPS survey development process. Next slide. Specifically, what I'm going to talk about is how, pardon me, as we develop CAHPS surveys, what are the steps we take with regards to capturing patient and family voices in healthcare quality measurement throughout all of the work that we do under the umbrella of AHRQ's Consumer Assessment of Healthcare Providers and Systems effort. Next slide, please. So for those of you who are new to CAHPS, let's just take a beat and walk through the development process. So every CAHPS survey or set of supplemental items starts with someone identifying the need for a new or revised survey. Maybe it's time to refresh a survey like the health plan survey that's been in use for some time, or there's a new aspect of healthcare that it's important to measure, thinking of some of the more recently published CAHPS surveys such as end-of-life care, mental health care. So every CAHPS survey begins with the identification of that need. The next step is to conduct an environmental scan and literature review in which we look at how others have measured this area, what are publicly available measures, what is known about what's important to patients in this type of experience, how has quality of care in this area been measured to date, how much or how little has been done. We then take that information and synthesize it and use it in our engagement with stakeholders. Now, who are stakeholders for CAHPS surveys? Well, they're patients who are receiving the care that's being assessed. They're the family members of patients. Sometimes it's parents or caregivers or spouses or other family members who can play an active part in assuring that patients receive care or interacting with the care system and seeing firsthand what works well and what works doesn't in obtaining care for their family members. They're the clinical providers, whether that's healthcare systems, individual clinicians, ACOs, medical homes, group practices. They're an important stakeholder in the development of CAHPS surveys. And last but not least, researchers who will use these data to measure and inform policymakers and others in assessing and monitoring the quality of care delivered to patients. We take what we learn from engagement with all of those groups and use it to develop draft survey items. And those items aren't delivered in a vacuum. We seek input from content experts, patients as we think about wording and how to approach. And then we go through multiple iterations of testing, refining the wording to make sure we're capturing what we intend to measure, test it again, do both qualitative testing through cognitive interviews, quantitative testing through field testing, where we look at how well the measures of support are performing, and multiple rounds of testing before we finalize the survey for use by the public. Next slide, please. So as we go through these steps, we interact at various points, as I've said, with patients and families. And the role of patients and families is really central to ensuring the surveys reflect real experience. I, as a survey methodologist, might have thoughts about how to ask about care, how someone speaks to care, what their care experience is. But as Mara has already spoken to, you really have to walk in the path of the patient to understand what their real lived experience is with regard to care. And we can only get that information from patients and families. They're involved early on, from early scoping, as I mentioned, in those early boxes, all the way through to final testing. Patients and their families provide input on what matters most to them in care, and that can differ depending upon the survey. If you're talking about facility-based care, such as hospitals, nursing homes, or hospices, the key aspects of care may be different if you're talking about what's important in a single ambulatory care encounter, something that might be captured by the clinician and group survey. And so the input from patients and families is very important in making sure that we're measuring what's most relevant for each CAHPS survey and each care setting in which the survey is administered. Patients and families are very important in assuring the clarity and relevance of the survey items. What does that mean? Basically, it means that in working and testing and getting input from them, we ensure that the language of the survey questions we write and the survey invitations that accompany those surveys is clear, understandable, and meaningful to patients. Next slide, please. Now, I've spoken a bit that we engage families from the beginning, and I just want to take a moment to make sure that I'm touching on all the methods or ways that we engage families and patients. And this begins early on in our exploratory work with focus groups, with patients or families, where we have open-ended exploration about what are their priorities for different care settings and confirm our understanding to make sure that we're using the terms that they use, that we understand their lived experience. We engage with them in cognitive interviews. Those are one-on-one interviews that are designed to test survey item wording and comprehension to make sure we're using terms in English and Spanish that resonate with patients, have common and consistent meaning or interpretation, and capture the concepts that we're trying to measure. We work with patient and family members on advisory panels from the beginning to inform all of our design and testing decisions, where to test, how to test, What changes do we make based on the data we're collecting during testing? How do we shape our final goals, and are we moving forward in partnership on these instruments? Last but not least, patients and family participates in field testing, both as participants, but helping us to synthesize the results to ensure if the final survey items work across all the different patient populations. Next slide, please. So how does, patient and family engagement benefit us? Well, it produces surveys under the CAHPS umbrella that are patient-centered and relevant, that are culturally and linguistically appropriate, given our work with all of the different patient populations, and are actionable for providers and healthcare systems, which is critical to CAHPS surveys. Just as importantly, it helps to build trust and credibility across our patient and provider stakeholder groups, providing transparency into the design process and allowing everyone to see a clear through line from the initial ideas and possibilities for the survey to the final products that are delivered. And I think I have one last slide in summary. So to summarize, patient engagement makes CAHPS surveys stronger. It ensures that they reflect what truly matters to patients. It improves the usability of survey results for patients, providers, and policymakers, and it supports better measurement, which leads to better care. And with that, I'll turn it back to you, Dale.
Okay, well, thank you. So that was an excellent overview of the CAHPS survey development process. And I mean, after all, this is a AHRQ CAHPS meeting, so we really wanted to address the importance of patient and family engagement in that process because it's so core to everything we do in measurement. We'll entertain questions between the two of you and our participants in a moment, but let me first now turn to Susan Perez, who will offer a few observations from your perspective. Susan, go ahead.
Thank you, Dale. That was incredible, anchoring in what we know and what we need to know about survey development. It's interesting and challenging is that when we as researchers are held to very specific methodologies and validation processes, and we often show up these communities and go, in order for this to be quote, credible and valid, I need to follow these exact steps. And what's beautiful about it is it's an and. It's an and in that you can get those methodologies done and you can meet the community, the patients, and the voices at where they're at. And it's about the nuance and that nuance that we struggle with. And I think that is the opportunity where we let our partners and those community members and those most impacted lead, which leads me to my next point is where and how do we get started with the patient voice? I think it's always about finding that key community partner. They may not be the people who are experts in research methodology, and I think there's always going to be I'm going to call them language barriers, but it's specifically the language of their experiences and traditions and cultures and values, and then our language as researchers. And in saying that and choosing these partners, it's the first step, at least I do, is I go to the data and say, where are the communities, the people, the populations that are struggling the most, that have the most harm, that we yet to have build the most trust with. And I know that's scary. It's scary because they're going to say there's going to be a lot of rejection. We don't trust you. And a lot of my colleagues say, how do we begin that? I think it's time. It's just being time and being in that community. And I know as researchers, as people who work for big institutions and organizations, that's often not how they're measuring our FTEs, or that's not often written in those grants. But I implore you to think about is this work for those individuals. It is their lives. It is their heart work. I really loved the conversation. What Mara was saying is it is an emotional exchange. Being on the community partner side I've experienced the hurt and harm of what happens when an institution and an organization lets you down. Or the ways in which they choose to interact is consistently like, wow, that hurts. Can we have that conversation? Are we there in that relationship? Will they fire us if we speak up? And that's absolutely scary. And that is what, being on those vulnerable sides is. But at the end of the day, sometimes they're willing to say yes because they see your power. They see your power and the ability to help them and move forward. I love this HCAHPS work because it is so meaningful to be able to go to a community partner and say, you get a say in how we measure your care. And it's so fascinating and saying it's tied to payment. So these hospitals and these institutions are motivated and you get a say. And I am going to work alongside you in partnership to empower you, and let's trust each other in that partnership. Let's spend time together. What's meaningful to them? And I think about in my own community, in my own family, what's meaningful to me. It's sitting out front with my neighbors. It's sharing a meal together. It's celebrating births and big life events. And that is important. And unfortunately, it's not always measurable. It's not always funded, but that is how we build trust. And also it's facilitating those connections and acknowledging, also I mentioned that positionality of power, what we're doing. It's really hard is because regardless of how much I come with my own lived experiences, and I know that maybe I've had struggles in my own life, and I want to bring that to them, and I want to meet people and say like, wow, we share those lived experiences. And yes, that's important. And that is an opportunity for connection. However, the end of the day, I represent the organization I am in the position of working for and being in that position of power. Often if I don't even agree with the organizational structure, or I'm so sorry, the payment structure is not getting you your stipends in time, you are still in that position of power. So it's always important to be mindful of that positionality. I really love too what Mara was saying is really be open to just being wrong. Sometimes, again, we're stuck to these timelines. This is my methodology, my protocol, 15-page protocol. I wrote it out. And I am saying to you now is be ready to burn it down and be really, really wrong. But at the end of the day is because, again, we've been privileged with this work, is we can pivot. We can write it up. We don't necessarily have to write about the twists and turns and the squiggly lines. It doesn't mean the work's not going to get done. I'm just saying is be really open to being wrong. And we'd rather get it wrong early versus implementing something that just doesn't work for anyone. So it's okay to be slow, moving at the pace of trust, moving at the pace of community, and realizing very early on and that it's wrong. And also building tools for implementation and meaningfulness is once we've put the survey out and once it's done, it doesn't mean we're done. What I'm really excited about with this HCAHPS work, specifically in the maternity space, is what are those tools as we've built it, we've done all the work, we've engaged all the right community partners. But what are those tools for implementation and continuing it and making it meaningful? Just because I've finished my project and it's out there, it doesn't mean it's done. And I know you all know that, but I think it's an ongoing conversation. I think it's hard because when we do this work, we're like, the project's over, and we pat ourselves on the back and it's done. But we absolutely know that the work goes on. And one of my favorite models for this is the Earth app. It's IRTH. They removed the B for bias. And once they've launched their survey, the survey's out there. It's incredible. They have high response rates because it resonates with people. They're asking the right questions. And once they learn this, they're going out into community and they're following up on their data. They're continuing to build infrastructure around their work and findings. And then I just wanted to really close with is advocacy and vulnerability going hand in hand is when someone is willing to speak up, they're speaking up from their lived experiences and harm. So it's really especially important that we listen and we're action-based in what we said is I heard you. And this is the ways in which we are adjusting, even if it's something as small as a word in a survey question, or as big as when your team does this, it's really hard for our team to respond, and therefore it's really important to listen, and it's for them to speak up and say something. It's really, it means a lot. And I love that also with Susan and Mara that they discuss falling in love with the problem and not the solution. And that resonated with me because so often as we're out doing this work and engaging with communities and partners, I'm going to say is take care of yourselves as researchers. Take the time for deep reflection. Some of my favorite times is going to these rural communities and that 5-hour drive home. I'm going to get emotional, where it's so fascinating as I sit in silence and I don't even realize it until I'm 3 hours in my drive, because those voices, experiences, vulnerability, and just the trust of being in a position where someone has trusted me, an outsider, to enter their world. And something that I know I personally struggle with, and what resonated with me is, again, falling in love with the problem, not the solution, is I really get stuck on hearing those stories and they resonate me. And I don't think it's a bad thing. I do think this is heart work, and I think I'm in the right place because it sits with me. But it's again, we have to learn to take care of ourselves and focus on the assets. It's those stories will stand out, those experiences will stand out. But at the end of the day, is we want to build on the assets and strengths of communities rather than sit with the problems and not the solutions. I'm going to pause there and open to questions. And thank you so much for letting me speak.
Well, thank you so much, Susan, for those thoughts. Very, very well articulated, and such a great compliment to the presentation that Julie made about how the process is designed to work for CAHPS surveys, and then your real lived experience from the community perspective and how that fits together. Just want to remind people that to ask a question, you just use the box, type it in, and then submit. And Julie, I'd like to invite you back on camera, and then maybe the three of us can sort of sit around here and kick around a few questions. So there were a few really good questions that were submitted prior to the kickoff this morning through the registration. Julie, I'm going to direct the first one to you, because there seems to be sometimes from the healthcare professional perspective a disconnect between what is sometimes heard on the floors and during rounding that are very positive experiences expressed by patients, and then kind of a surprise that the survey results, for example, with HCAHPS, don't really reflect that same thing. So do you have any sort of things or comments on how to sort of deal with the sort of the apparent contradiction in positive feedback during the stay and then more negative feedback post-stay in terms of survey results?
Sure. So I think we have to remember that, when we're giving care to patients, they're very vulnerable, right? And so it's a very vulnerable situation to be in. And so I think that point in time conversation with the patient where they're thankful and grateful for the care that's being delivered is useful. But I think where, say, the CAHPS surveys come into play is after the patient has been discharged and has had an opportunity to think about that experience, think about how am I feeling now, think about what occurred, how well did my interactions prepare me for going home? Did I go home with all of the information that I needed? Did I get help to make sure my follow-up care was just going to be what I needed? It takes you from that in the moment of that one-on-one action to really reflecting back on how well were my needs met throughout that stay. And so that can be part of the difference that some providers see.
Right. And would you also say that there is a role, in addition to the post-discharge survey process that CAHPS uses for hospital stays, there is some place for real-time survey collection and dissemination during the hospital stay?
Well, this is where I'm going to get into like my personal opinion, where I think what can be really helpful during a hospital stay are some of the complements to CAHPS surveys, like patient shadowing and field visits and observations, and some of the other tools that can give that real-time feedback. There are definitely ways to integrate CAHPS into all sorts of quality improvement efforts where you're using it as part of real-time measurement. But, working with you and Susan and others always makes me mindful that there's some tools that supplement those standardized surveys that can be really useful and powerful in providing some real-time information.
Yeah, it's a really good point. And we've had a number of webcasts and sort of briefs that we've published on the fact that CAHPS surveys are an important, essential starting point. But there are certainly multiple other ways of gathering and using patient feedback along the lines that you've just described. Susan, I wanted you to sort of build on a comment that you made. Julie has very clearly described the role of patients and families gathering their voice when surveys are developed and tested. You made the point, I think was very good, that after all that is said and done, and we have a CAHPS survey or another patient experience survey, what is the role of engaging patients and families in the process of implementation, even administration, and then use of surveys? I mean, I just wonder if you see an opportunity there that we're not capitalizing on or that could be strengthened.
Absolutely. I mean, there are actually, we know is there's a number of hospitals that have patient advisory boards that they bring patient voices to QI initiatives, which I think is incredible. But some of the most interesting models for that collection, so I think there's two levels, is getting the feedback, because sample size is so key to this, and we know that in certain communities that there is less of a response to these surveys. So there's that. What's really cool, and it's specifically to maternity care, there's a great model that is happening with the doula organization in partnership with the University of California, San Francisco, where they're having the doula organization collect those patient experience measures and those surveys, and also engaging and being a part of how they respond, that quality improvement process based on those responses. So one, it's that trusted source, it's engaging key community partners and those bridges, and it's keeping that conversation going. I think what's really incredible too is in my understanding, it's a true partnership where that doula organization feels like they are essential and working in parallel to that work. For example, UCSF wouldn't get the responses they needed if it weren't for that doula organization, and the honesty, the sincerity, and the truth of that feedback is, I think, in my opinion, actually a little more more valid because of the way in which they're gathering the data.
Yeah. So I think your comment is excellent, and it sort of gets us to think about the overall arc of the process of engagement, where in terms of gathering feedback through through surveys and other methods, that's the starting point. And then actually sort of the involvement in the use of the information, the improvement process is analogous to the arc of our meeting today. So it is a process. It's not just doing the collection. It's the gathering and the use of the information for improvement. And that's the other element of engagement that we're going to be touching on today. In your comment just now, Susan, you talked about the doula example of helping to gather feedback from patients that may not be as responsive to traditional administration methods. And Julie, before the meeting, again, there were several comments, and we always get these about what can be done to maximize responses to the surveys that are developed, particularly CAHPS surveys. After all the effort that goes in that you've described, we've got a great instrument. How do we think about maximizing people's participation in those surveys? Do you have any thoughts on that?
Well, I still think even in this day and age, Dale, a lot of it goes down to making sure that you have accurate contact information, like making sure that we really are reaching patients at the correct, whether it's email address, mailing address, phone number, however we're reaching out to them. I found a lot of times that the very accurate information that's at, the front lines of care, the site of care, doesn't always flow up through the systems. I also think that, we talk about partners in care. There are things that clinicians can do to publicize the survey in a non-directive way, in a non-leading way, such as informational posters, just letting them know that their voice is heard, that their voice is important, that can also help to improve response. And last but not least, I'll put in a plug for always using multiple modes of data collection. Web and phone is a great way to, boost response. There's no, one size fits all approach to collecting the data.
Right. Susan, I want to go back to you and just have you think a little bit more about what it takes in engaging community members and other stakeholders, patients and families that that may not have the sort of the background. How can we think about engaging people who may feel at a disadvantage and maybe at a power disadvantage in participating in the process that Julie's described? So from your own experience, for example, as a member of a technical expert panel, how did it feel and what kinds of steps could be taken to actually make it easier and more possible for the non-researcher perspective to engage in the process?
Yeah, I think there's some incredible models and right now of how hospitals and institutions and organizations, even like such as AHRQ, are engaging those community partners. We as the researchers don't necessarily always represent the community, and in the scope of a project, our work or the implementation might not garner that trust. So I think there's huge opportunity to work within the systems that already exist. The value and beauty of that is that those community organizations will always be there. That is their lives, that is their lived experiences, that is their work. And so to answer your question it's absolutely about finding those key partners, finding that key voice or even the gatekeeper to those communities. They are the trusted resources. They will make it happen. One of my favorite examples is that in my qualitative research, I've worked with focus group houses. I've worked with universities and then community-based organizations for recruitment. And it's so fascinating is every time I work with a community-based organization, I go, I will say, okay, we need 10 people for the focus group. Let's recruit maybe 13, 15, some people won't show up. every time I do with a community partner, they get like 100% response rate and people showing up. And if someone's not showing up, they're texting somebody else as that backup. And
So,
it's
yeah.
incredible with our focus group houses and our and when I'm trying to reach out on behalf of the university to recruit, it's like we absolutely have to recruit 15 to try and get that 10, and maybe we're even at 8 sometimes. And it just shows the embeddedness. I think that example is anchors me in saying that the engagement of those communities absolutely increases the validity and improves the methodological process for me as a researcher. I mean, we think about response rates all the time for our surveys, how, I send out 100 surveys and we're okay with maybe 80, but those community partners positioned right, they'll get you those response rates. They'll get people to show up. So
Yeah.
it is an incredible asset. And again, it is about building that foundation in the community. I always think about that. My goal as a researcher is if I do nothing else, that I have strengthened this community to do the work or to improve their outcomes within their community, even if nothing else happens.
Great. Julia, I'm going to ask you kind of a out of the box kind of question. I hope that given our friendship, um, given the challenges that Mara set out in terms of the design challenge and the way she framed human-centered design, could I just ask you to think, having clearly outlined the development steps for a CAHPS survey and being a part of that process for at least 30 years, is there anything that you would do differently based on the points and principles that Mara articulated in her keynote?
Oh, sure. I mean, I think I can't remember. I think it was, Susan and others have said, just because we ask the questions and get answers, it doesn't mean that we're done, right?
Yeah.
And so I think that one of the most important things is, if you think about how CAHPS has changed over its lifespan, right? And how we've gotten more adept at engaging community-based organizations, other patient stakeholders, and patient communities. And I just see it as a natural evolution. So I think that, over time, there would be greater, patient developer partnership. So imagine a CAHPS consortium that includes, patient representatives. I think I don't want to use the word challenge because that sounds negative. I think like the something to think about there is we've partnered with a lot of great people and a lot of great organizations throughout the development of CAHPS. And sometimes the partner you need for a specific instrument or a specific set of items is the partner you need for 3 to 6 months, and then you need a different partner for something else. So it's thinking about how to foster those kinds of relationships and helping everyone to to continue to be engaged and see how their information's being used. But yeah, I think there's still room for change and to grow. I think one of my very first AHRQ projects used something closer to this co-design model. It involved developing surveys for patients with HIV, and it was just a great chance to educate everyone and to work collaboratively. And I think that, it's a continuum, and I think that there's always room for change in how the CAHPS consortium approaches survey development. And I'd like to think that, that's a philosophy that we're all happy to embrace.
Agreed. Great. Thank you. That great reflection, great answer. We have about 4 minutes left in this session. I want to get to a couple more questions. Susan, you've touched on this already, but I want to make sure we address the question that is framed that do you recommend hospitals communicate back to communities about the feedback received and then offer the steps they are taking to address or partner with them to improve? So I guess we're talking about maybe a feedback loop of information that is not just what we receive in terms of patient input and feedback, But then do we tell the communities that we're surveying or asking about what we're doing and what are the advantages or challenges of that?
That's the answer is absolutely yes. And I'll offer a recommendation is that the hospitals partner with the community organization to lead that and then to lead that and even host it. So they say if we reach out to that community partner and say we have all this incredible data, and I believe the individuals, the clients and individuals you're serving would be interested in this data. And I do think it's what's really beautiful is when the hospital data team is enabled to have a conversation with that community partner and dive deep into the data and say, what of this data is meaningful and what are the ways in which we can present it to ensure that it's understandable, meaningful, and they receive it well. Sometimes how we communicate data and report can also perpetuate harm. So it's important that you anchor in that. I also think those actions taken is also a conversation, to be in conversation of like, this is what we learned and this is what we're doing on the hospital end, but can we learn more about what more we can do, or what do you need from us? And also, I understand there is this HCAHPS surveys, but also there are other questions and other metrics that might be meaningful to that community that even engaging and beginning the conversation, they'll learn. Like, we did not know that this is something important to you that's unique to this hospital relationship with the communities we serve. Let's have that conversation, and we'd love to start asking those questions.
Yeah, terrific. One last question before we shift gears into our next session. Because this comes up a lot, Julie, I'm just going to pose it to you in terms of you've defined the survey development process, how it gets done, how in-depth it is and detailed. How often is that process repeated in terms of updating what a CAHPS survey needs to do to respond to changes in practice or the environment or evolving patient needs and preferences?
Sure, that's a great question and an important question. So I think a great example that comes to mind is telehealth. So think about what AHRQ did to update existing CAHPS instruments to make it explicit that telehealth should be included. And the process that was followed there was, going to the literature, engaging with stakeholders, doing qualitative testing, making sure that we were really using terms that resonated with patients and matched how their clinicians were speaking about it. So I think an important thing about CAHPS surveys is that they're not static, is that we update and refresh them over time, especially as patient priorities change, how care delivered changes, all of those influence generate the need to update and refresh these surveys, or they lose their utility and effectiveness.
Right. Well, thank you both again so much for your comments and your perspectives. And I think we've learned a lot about CAHPS and how CAHPS is viewed and how it's developed. And Susan, how the community can engage with that process and then beyond in terms of genuine engagement, not only in terms of collection, but use of the information for improvement.